So I'll share my screen now. So now you should have a glorious Ferrari. The
Absolutely.
488 Pasta. Isn't that just so beautiful?
Oh,
It,
that is great.
it sort of beats dermatopathology, doesn't it, really?
Yeah.
Now, do you want to say anything before I get
Yeah.
going, or
Yeah, please let me just do a few introductory words and then I'll hand it over to you, if that is all right.
yeah, we need to get someone to stop talking.
I'm just trying to see who it is and I can. Yeah, I found the golden guilty person.
Gosh.
Okay. Right. Good afternoon, colleagues. Good morning to some of you, depending where you are in the world, and good evening. Welcome to the Department of Oral Pathology and Oral Biology at the University of Pretoria, our guest lecture opportunity. We are indeed today really privileged to have in our midst Professor Philip McKee. I'm sure most of you know Professor McKee, but just in short, he obtained his Bachelor's of Medicine from Queen's University in Belfast in '71, followed by his pathology training at Royal Victoria Hospital, when he emanating in membership of the Royal College of Pathologists in '78. He then completed his fellowship in dermatopathology at St. John's Hospital for the Diseases of the Skin, and became a fellow of the Royal College of Pathologists in 1989. He was subsequently in 1992 awarded his doctorate in medicine from Queen's University in Belfast. Professor McKee then moved over to the US, where he had prestigious positions at several prestigious institutions. Of note is that in 2005, we in South Africa were fortunate that he was a visiting professor to the Department of Pathology at the University of the Witwatersrand. He has also been a frequent lecturer at the DermPath meeting arranged by Professor Wayne Grayson in Johannesburg. He's been spending considerable time visiting medical centers in both the States and abroad, and lecturing and presenting slide seminars. He's the author of more than 160 papers in peer-reviewed journals and has contributed to numerous textbooks, notably the McKee's Pathology of the Skin textbook, which is, in my opinion, the best there is, and it's now in its fifth edition. Until his retirement, he has been was host of the Teaching DermPath website. Prof. Philip is currently residing in a small rural town in Western France with his wife Grace, and as he explained, that has been in lockdown almost for the last number of months. Very importantly, I think in 2017, he started the Facebook DermPath consultation, teaching and research group, which on last count has over 17,000 members and continues to provide a pro bono dermatopathology consultation service. And I think it's this last sentence that for me really speaks to Professor McKee, that he's available and prepared to spend his time to share his immense knowledge with us as colleagues from all over the world. Prof. McKee, from our side, thank you very much. Welcome to this forum in South Africa. We have been fortunate to have you many times here. We're looking forward to your presentation. The stage is yours.
Okay, well, thank you very much. You actually made me feel rather sad as I listened to you, because it brought back memories of our trips to South Africa, which have been curtailed by COVID. And as you know, we had an almost annual pilgrimage to Johannesburg to see Wayne and our friends there, and then to attend the dermatopathology meeting and meet up with all sorts of characters, and after which we regularly trooped off to the Kruger or Pilanesberg and had our fill of wild beasties. And it has been my privilege, you know, it's been a great privilege to have all these trips to South Africa. It ended up really that South Africa has become almost like a second home. And I often thought if I couldn't live in France and I couldn't live in America, which are my options, then South Africa would come up next. So now I'm going to put this into a slideshow and see where we are. Now, one of the things I have to tell you is I don't know anything about oral pathology, absolutely nothing. Fortunately, in my life, throughout my entire career, I've had somebody else do all the oral pathology and salivary glands and all that sort of stuff. So there is no point in asking me questions about dental tumors and salivary gland tumors, because it's as much a mystery to me as perhaps sweat gland tumors might be to some of you. Now, I started this whole thing started off as a 1-hour lecture on tumors that might interest the head and neck pathologists, which was fine until I started thinking about it, and then I realized that there are so many cutaneous epithelial tumors which may occur in the head and neck region, and you guys particularly oh, that's interesting. I think we've got a very young member in the audience. That you guys may well have problems with all sorts of malignant appendage tumors. Because of that, I decided I'd better make it into more than one lecture. And I don't know how many lectures we're going to end up with, but it'll be quite a few. And I'm going to start off today talking about sweat gland tumors. This is sort of sweat gland tumors part 1. Now, in the old days, we used to get terribly tied up into whether tumors were of ecrine or apocrine derivation. And then somebody, and I don't remember who, described the apoecrine gland, which I was never very convinced about that, but I left it there in case somebody is a firm believer in them. And then, of course, we've got the mammary-like anogenital sweat gland tumors, which are tie up really with apocrine tumors. So, as I say, in the old days, we were worrying, we seemed to get very caught up in all of this, which really is a total waste of time. It's really of no consequence from a practical point of view as to whether a tumor begins life in the ecrine or the apocrine camp. What really matters is whether it's benign or malignant, and I suppose that goes without saying. And when I think about malignant sweat gland tumors, I've always divided them into low grade and high grade, and that sort of makes great sense. And you know, when you're in a difficult situation and a tumor is not really following the rules, so it's hard to classify it, the best thing that you can do is at least try and divide tumors into low-grade tumors or high-grade tumors. And if you can do that, then that's half of the battle. Although it's obviously very nice if you can put a precise name on the tumor. And low-grade tumors, by definition, recur, but they hardly, if ever, with the exception of adenoid cystic, metastasis is exceptionally rare, whereas high-grade tumors, metastases are much more common. So that's a sort of a starting point. So today I'm going to start. Talking about a variety of low-grade sweat gland carcinomas. And while I remember, if you could remind me when the hour is up, because I will not notice the passage of time, and I'll talk on forever. So you've got to say, right, that's the hour finished. So low-grade sweat gland tumors, they include all of this lot. And I'm going to talk today mostly about microcystic adnexal carcinoma and solid carcinoma, which some people regard as a variant of microcystic adnexal carcinoma. And if I have time today, I'll touch on eccrine epithelioma and adenoid cystic. But I don't suppose I'll get to these ones today. But we'll get to them at a different on a different occasion. Now, it's really strange, you know, because microcystic adnexal carcinoma is, in my experience, the most common sweat gland carcinoma that I ever see. And I almost had this idea in my head that it was a common tumor, when in reality, the incidence of MAC is 0.16 to 0.65 per 1 million of the population. And I've seen 60 or 70 of them, and then of course I had to realize that these were nearly all referrals or consultations. And so my experience is totally skewed. But nevertheless, having said that, on a personal basis, this is my commonest tumor, and it's by far my most favorite cancer. I think this is a great tumor. And this clinical picture on the right, this is the very first microcystic adnexal carcinoma that I ever encountered. And this was a woman in her middle ages. I don't remember quite how much, what her years were. And clinically, she presented with this sort of rather, slightly scaly, and it was a bit indurated, and she had some tingling associated with it. And the awful thing was, subsequently at surgery, if I put my arrow round, the actual tumor itself was more like this size. It was a huge tumor. And that's one of the most important things about microcystic adnexal carcinoma, is it's very deceptive clinically. And when you look at a patient and you think you've got the lesion marked out, you'll always, when you get to surgery, you'll always discover it's much bigger than you thought. And now I just put this at the very bottom. There are some cases in the literature of metastatic microcystic adnexal carcinoma. I think there are about 4, and I wasn't really very convinced whether they really were microcystic adnexal carcinoma or not. And recently I posted a comment or a question on McKee Derm, which, as you said, it's got about 17,000 members who are all dermatologists, dermatopathologists, or pathologists. So the audience is huge. And I asked, has anybody ever seen a metastasis from a MAC? And not a single person had ever seen one. So I think it's very doubtful whether these things have any metastatic potential, but they are nevertheless extremely aggressive tumors, and they need to be treated as such. Now, these are cases that from my own files. This is that lady I showed you a moment or two ago, and there's one occurring on the eyelid, and you can see there's an ulcerated sort of nodular lesion there, and you can imagine how dreadful that will be to treat. And that little thing there on the nose is a MAC, and this is a recurrent tumor. And there are little blue dots around around what was thought to be the border, and this is all microcystic adnexal carcinoma. And then I borrowed some images from the literature, because I thought this was a rather splendid case that clinically looks awfully like a BCC. And this particular case was misdiagnosed clinically as a BCC, and I can see why. And then this is another case where it presented with at least 5 sort of independent nodules. So it had a multinodular appearance. And then I had to put this one in, because it's hard to see the tumor. The primary tumor is on the eyelid, but there you can see that the MAC has invaded right through into the patient's cavernous sinus, and that's one of the reasons why this is a terrible tumor, because it can spread very deeply. And in fact, although I've not experienced it myself, there are cases in the literature where the tumor has grown along the cranial nerves and has actually ended up with a sort of a carcinomatous meningitis, which is a pretty nightmarish scene. Now, what about the histology of microcystic adnexal carcinoma? Well, I imagine that most of you are going to be fairly experienced in diagnosing this tumor, so my talk at this point is really directed against or directed towards the younger folk. And this is a sort of a contentious area, which is not really very important. But people get into heated discussions as to whether this is a sweat gland tumor or whether it's actually a follicular tumor. And I don't really care which you choose to think. From my perspective, microcystic adnexal carcinoma shows sweat gland and follicular differentiation, which even may include sebaceous differentiation. Where it's coming from, it doesn't really matter. And it's a biphasic tumor. At the top of the tumor, you tend to see these keratocysts, which generally show infundibular keratinization, but they can sometimes show pilar differentiation, or it can be a mixture of the two. And occasionally, it looks more like external root sheath, and so you get clear cell change, which can be very marked, and so you can end up with a diagnostic confusion as to whether this is a clear cell change in a MAC or whether it's a clear cell squame or a trichonemal carcinoma, and we'll get to that later. And then the deeper part of the tumor is composed of these solid, narrow epithelial strands, and you can see these in this image at the edge, just outside the keratocyst. You can see the epithelial strands, and the important thing in terms of differential diagnosis is the keratocyst bit should appear benign. You do not want to see carcinoma in situ in the squamous type epithelium around the cysts. And typically in the epithelial bit, it looks very bland cytologically, and I'll show you that in a moment or two. And then as part of the diagnosis, you have to hunt around for ductal differentiation, which is invariably present. And as you know, the the big differential diagnosis for a MAC is desmoplastic trichoepithelioma. That's the one that people get hung up on most. And this is the absolute differential diagnostic feature. In MAC, you see ducts. In desmoplastic trichoepithelioma, you do not see ducts. So that's very important. And in my experience, microcystic adnexal carcinoma almost invariably shows perineural infiltration. Not invariably, but almost invariably. And in contrast, desmoplastic trichoepithelioma does not. Now, I want to make a point from the point of view of the clinical distinction, because it can be quite a problem. The two tumors can look similar, and to make life more difficult, desmoplastic trichoepithelioma has quite a high recurrence rate. In some series, up to 40% may recur if incompletely excised. And so you need to bear that in mind before you think, oh gosh, I've misdiagnosed a MAC as a desmoplastic trichoepithelioma because it recurred. It's just a fact of life you need to be aware of. And these are all images from the very first case I've ever seen. And this is, if you like, is prototypical MAC with keratocysts at the top. There are some solid nodules, which I'll get back to later on, which are commonly present. And then at the bottom of the lesion, these are the narrow epithelial strands. And you can see that the nuclei might be a little bit hyperchromatic, but there's not much in the way of pleomorphism. And nucleoli are not prominent, and you don't typically find many mitoses in a MAC either. In fact, it's not worth you are looking for them, to be honest with you. And this is a field showing clear cell change, and there you see tricholemal keratinization or pilokeratinisation, and it's almost like it's got an external root sheath around it. So this is why people are quite keen on the tumor being at least biphasic, if not just follicular. And these are the ducts that you have to look for. And if you can't find them, you need I'm not a great enthusiast for immunohistochemistry, to be honest with you, and I suppose that'll become quite clear as we talk over the next quite some time. I have this faith. It's not totally unshakable, but it's pretty close to unshakable, that if you don't know what the tumor is on the H&E, then you've basically had it. Now, having said that, there are some simple things you can do, and I think it's well worthwhile doing. If you can't see any ducts, do a diastase PAS if you don't have immunohistochemistry at your laboratory, because that'll outline the cuticle of the duct. It'll be diastase PAS positive. And if you do have immunohistochemistry, EMA and CEA are the two antibodies that I have faith in. And this is skeletal muscle at the bottom, and you can see the tumors growing down into it. And this was a field of the same tumor showing solid aggregates of cells. And this, I think it was Bernie Ackerman I think he started off on the solid variant, which I'll come back to shortly. And again, this is that first tumor, just again showing you more clear cell change with a close-up view there, and that is due to glycogen. If you did a PAS, that's positive. And there's nice, rather more tricholemal keratinization. And here you see it's almost ubiquitous perineural infiltration. Now, I just want to touch on this very, very briefly. Some people, and I have to confess I'm one of them, used to get very excited about calling tumors eccrine epithelioma as if they were a different entity, which I now apologize to all of you, because I think eccrine epithelium is just a variant of MAC. But back in the day, I was quite excited about it. And I wanted to tell you a little story about this tumor. It was first described by Richard Winkelman, who the older folk in the audience will know of him. He was a very, very famous dermatologist and pathologist in the Mayo Clinic back in the 60s and the 70s. And he used to publish these papers with enormous numbers of cases of tumors, and so that anybody else's case series always looked a bit pathetic, because Winkelman had published 100 cases when you were trying to publish your 12. But anyway, Richard Winkelman first described eccrine epithelioma, and here's something that I think is quite important, and that is when one is looking at the literature, sorry, yeah, thank you, one has to be very careful, and it's very important that when you read old literature, you actually read the article and just don't read the abstract, because you'll find there's an awful lot of inaccuracies and inaccurate diagnoses the further back in time you go, and perhaps nowadays as well. But at least the original description of eccrine epithelioma, when you look at the images, they're actually adenoid cystic carcinoma. They're not eccrine epithelioma at all. And so Winkelman first described adenoid cystic carcinoma. So the moral of that story is make sure you read the literature. And all this tumor really is MAC without any keratocysts. It's just one half of the tumor, but morphologically it's identical, and you can see these strands in a rather collagenous stroma. And I suppose the importance is, if you don't notice any ducts, you might misdiagnose this as a morpheaform basal cell carcinoma. Although from the point of view of prognosis, one tumor is as bad as the other, but we do like to get the diagnosis corrected if we can, and so you have to go hunting for ducts. And there's the same tumor growing down a little nerve there. Now, I've got a few more examples to show you, because as I've said, I think this is a very, very important tumor that you get the diagnosis right. And for the younger folk who haven't seen cases, I thought I'd put in a few so that by the time I finish talking, you'll have seen lots of them. So this is a case that was posted on Kiko.com. Now, I don't know whether any of you guys know Kiko, but this stands for knowledge in, knowledge out. And it's a program that's run by a nice guy. He's a friend of mine called John Han Ho from the University of Pittsburgh, and it's a fantastic site. So you can join it, and they on the site it's mostly whole slide scans are posted, so you can look at the whole tumor and play around with it, and it's very, very good, so I recommend that to you. Anyway, I don't know the clinical history of this case, but you can see that it's a crusted lesion that's extending deeply down. You can see it's going down in skeletal muscle there. And the other thing you can notice is that there's quite severe sun damage, although UV light itself is not that does not cause microcystic adnexal carcinoma. It just so happens that sometimes you see both. And here's a closer view, and there are the keratocysts at the top. And there you can see narrow epithelial strands going all the way through the dermis. This slide's on its side, but there's some gross elastosis there, and there's very obvious ductal differentiation. But again, it's the epithelial cells are bland. So that's the important point of view from differential diagnosis, is there should be minimal pleomorphism. And I included this case because you see there are some nerve fibers, and there were, oh gosh, there were maybe 10 nerves in that piece of tissue, and every one of them is showing extensive perineural infiltration. So you can see this was an absolutely hideous tumor. And then I had a case recently, in fact it was posted about 2 days ago by Bernice Yen from Taiwan, and I thought this was a gorgeous case and a little bit more interesting, because normally you tend to see the keratocysts at the top, but in this example they're scattered throughout the whole lesion, and it's a real muddle. And a little bit confusing, but nevertheless, when we look at it close up, aren't those gorgeous, gorgeous keratocysts? You couldn't ask for nicer ones. And then here we see skeletal muscle and the glandular component showing good ductal differentiation. And again, I can't emphasize it too much for you. Notice that there is no nuclear pleomorphism in this tumor. It's very bland, and you will have to work very hard to find mitoses. Now, some of you, and I know this from bitter experience, some of you are mad keen on immunohistochemistry, and I suppose the one that I pay attention more than anything else is, well, EMA and CEA. This is CEA emphasizing the ducts, and it's very beautiful, but those ducts were pretty obvious on the H&E anyway. But I think Burr EP4 is probably a useful stain to have in the back of your mind, because sometimes if it's very sclerotic, it may look a bit like a morpheoform BCC, which would be positive, whereas MAC is negative. I forgot to put in that P63 is also positive in a MAC, because very often you'll get a myoepithelial layer outside on some of these ductal structures, and I think I've got that to show you later. So, there were 3 cases, and this is obviously during Mohs surgery, and it just shows you this how large the tumor can be. It's a rather gory picture. And there's no doubt, I think there's no doubt that Mohs surgery is very good in terms of minimizing the cosmetic damage that you do to the patient. But in reality, plastic surgery versus Mohs surgery, the recurrence rate is pretty much the same. And that's a sort of a broad spectrum of recurrences, but it's certainly on an average at least 25%. and I've talked about that. I would make the point that, in my view at least, it's best not to use radiotherapy on these tumors, and that's particularly because if you do, you'll fry the dermis, and then when the tumor recurs, it'll recur in the presence of sort of concrete, and be very hard to be very hard to treat the recurrence. So that's worth bearing in mind. I will admit there are publications in the literature using radiotherapy, so maybe I'm a bit old-fashioned on it. Now, I wanted to bring this one in, and this is a case that Antonina Kalmakova from Kiev shared with me, and this is the so-called solid carcinoma, which some folk regard as a variant of MAC, and I don't really have fixed views on it. Maybe it is, maybe it isn't. I don't know, and I don't really care too much whether it is or isn't. The important thing is recognizing that it is a low-grade sweat gland carcinoma, and I'll show you some images. Now that's the piece of tissue that Antonina shared with me. There were 3 bits of tissue. There were great big chunks, but we don't have the epidermis evident anywhere, so I can't show you the top of the tumor. But here's the bulk of the tumor. There's skeletal muscle, and you can see it's composed of these solid aggregates, very similar to the ones that I showed you when I was showing you the H&E of a standard MAC. And here's a field from the tumor. Whoops, hang on, it got carried away. There you can see that there is keratinization with small, if you like, we can call them keratocysts, and that was at the edge of one of these 2 pieces of tissue, but most of the tumor was composed of the solid stuff. And if we look a bit closer, you can see the keratinization there, the solid component there, and again the nuclei, there's mild pleomorphism, but it's not desperately so, and that's just a bit of keratinization. And ductal differentiation was quite hard to find on the H&E, but there's a well-formed cuticle there, and I think it's slightly it's rather refractile, but I think that eosinophilic curve there may represent the same duct cutter in a different plane. And you can look at the high power of the nuclei, and it's mildly pleomorphic, but nothing spectacular. And there, it was hard to get this in focus, but there's a nerve showing perineural infiltration. And then, now why did I put this in to show clear cell change. And this, if you did no, hang on a second. I'll tell you why I put this in. I put this in because now it's going to be a matter of opinion. At lower power, I thought this was clear cell change, and then I was trying to convince myself that I was looking at scalloping, and I thought, now, could that be sebaceous differentiation? Well, it might be. I wouldn't want to spend too many dollars on a bet, but I suppose it's possible. But that's why I took that photograph anyway. And here's the immunohistochemistry, which inevitably gets done. And there, P63 is quite nice because there's clearly a duct there, and there's a duct there. So the P63 outline ductal differentiation, and these are the myoepithelial cells. And the tumor is CK7 negative, and it's CK5 positive. although personally I wouldn't have done those antibodies anyway, so I'm not sure I can get too excited about it. And I think this is the CK5 in high power, but it doesn't really tell me anything useful. And then I put this one in. This is another MAC, but this one is not showing any of the keratocyst formation. So this is, if you like, in the old days we would have called this eccrine epithelioma. Some people call this syringoid eccrine carcinoma. But I'm coming to the viewpoint that we need to get rid of a lot of these terms because they only make life difficult. And I think we can just regard this as a variant of MAC. And there's a close-up view, and there's a nerve. You can see perineural infiltration there. And you see the tumor is just these narrow epithelial strands dissecting the dermis and associated with a dense stroma. And there's a higher power view. And again, notice there's no significant pleomorphism. And that's a higher power view, just showing you the same thing. And there we can see some ductal or even glandular differentiation. And as I say, if you look, you'll always find it, and there's a nerve there, so it's showing perineural infiltration. And no surprises, this one had a whole bunch of immunohistochemistry done too. And the EMA was useful. It outlined some ducts within the epithelial strands, as did CEA. And P63 was quite useful, showing the biphasic nature of the tumor. And Antonina went mad on this case and did all sorts of things, and I'm not going to get myself involved in it. I'm showing them to you because you guys probably live, eat, breathe, and sleep immunohistochemistry, so you can look at those and make your own opinions. And then this next case, whoops, now this is the most spectacular case of today's presentation, which was shared with me by Professor Matthias Bobos, who's from the University of Thessaloniki in Greece. And it's just a magnificent case. And it's a patient with a long-standing tumor on the scalp, and this is a scanning view, and you can tell it's the scalp because this is the Gallia aponeurotica, and so the skull. I'm surprised we didn't get a bit of bone with this as well, but the skull would sit down there if you had a bit, and you can see there's a tumor going all the way from the epidermis through the dermis, through the gallia, and it's invading all over the place. It's just a horrific tumor. And then there's another tumor in the adjacent skin. This tumor is quite different from this tumor. There are two tumors. And in fact, there were three tumors, and I'll show you that in a moment. And this in fact is a Nevus sebaceus, which we don't actually have the histology of the Nevus sebaceus, but that's what this arose in. And it's one in which the patient was really unlucky and developed three tumors. And I'll show you those in detail. Unfortunately, these were images that Matthias shared with me, so that's the only image I have of the squamous cell carcinoma, but I think it's a bona fide squam, and it looks quite different from the other tumor, the second tumor. And this is the second tumor, which you'll all recognize, I hope, quite quickly. There's apocrine decapitation, secretion, or apocrine snouts. I must say I hate that word snout. It's sort of a revolting term, but it's stuck in the literature, so people use it. And if you look carefully, you can see there's stuff full of plasma cells, and there's the surface, there's the squamous epithelium going down, and then it's continuous with this glandular formation. So this is syringocyst adenoma papilliferum. So we've had a squame, we've got syringocyst adenoma papilliferum, and then we've got this tumor, which is another one altogether quite different. And this, you can see, looks like the ductal bit of a mac with narrow epithelial strands in a very densely sclerotic stroma, and it's going right through the muscle coat towards the fascia. And there you can see ductal differentiation there. And there's a bit there which looks awfully like a morpheaform BCC. So it makes the point that that would be in the differential of that particular field, not the rest of the tumor, obviously. And this one was crawling around every nerve in sight. There's a nerve there. There's a nerve there. There's another one there. There's glandular formation or ductal differentiation in the perineural sheath. And look at that nerve. It's got, I mean, this is just such a dreadful tumor. And, well, I don't think you need immunohistochemistry, really. That's just another microcystic adnexal carcinoma. But anyway, it got immunohistochemistry done, and that's a keratin of some sort. I've forgotten what it is. And this is EMA or CEA, and this is the other way around. If that's EMA, this is CEA or vice versa. I forgot to label them. But the point I wanted to make to you is, if you want to save money, a diastase PAS is all you need, because they're beautifully, it shows you those ducts in the perineural sheath. So really, that's the poor man's guide to sweat gland tumors. Don't forget diastase PAS. And so, what's the time? Have I got 10 minutes left? Hello?
Yes, Prof. We started a bit late, so make it 15 minutes.
Okay, well, I'll carry on then. I just wanted to touch on Nevus sebaceus, because that's something that's going to perhaps crop up in your daily practice, largely because of the tumors that may arise within it. Mostly this will get chopped. Well, it'll be identified clinically by the dermatologist or the pediatrician. They're very easy to recognize. They always have this yellow marmorated or almost cerebriform. It looks like a bit of the brain is stuck on top of the scalp, and they're fairly common. So, in the neonatal unit, you'll see them not uncommonly, and you may get multiple linear nevus sebaceous presenting in patients along with neurological symptoms, and so on. Schimmel-Penning syndrome with skeletal, cardiovascular, etc. And then the scalp syndrome, which is nevus sebaceous with CNS malformations. But fortunately, these are all desperately rare, terribly rare, and you're not likely to encounter them other than in the literature or at a meeting. And this is a lovely clinical, and you can see why it's called nevus sebaceous, because this is scalp. And you can see that sebaceous gland is discharging directly on the surface of the scalp, and there's a little basaloid proliferation there, and that's that's, if you like, is a sort of a mini trichoblastoma or trichoepithelioma. In the old days, when we saw these, we used to think they were superficial BCCs, but they're not. They're trichoblastic. And there's a little bit of the molecular changes in Nevus sebaceus, but I wanted to make the point to you that although we call it sebaceus, that's actually a misspelling, and my computer keeps putting the O in, although I try and delete it, but then I don't notice, and it's gone back in again. But it's actually a hamartoma of the whole skin. So you get abnormalities of the epidermis, the hair, sebaceous glands, and you find apocrine glands in this lesion. And as you know, you don't normally get apocrine glands on the scalp. And this is a low power view. And you can see that this is scalp skin. You can tell that because of these great big hair follicles going down into subcutaneous fat. And then the hairs stop. So you can see now that this is the histological correlate of the alopecia that is characteristically present in Nevus sebaceus. And in this field, you can see some high-level sebaceous glands. These are the foci of trichoblastic germ cell proliferation, if you like, that are very commonly seen in Nevus sebaceus, and these are the heterotopic apocrine glands. And the important, you see, it's done it again. I apologize for that. The tumors which you may see in it, most commonly syringocystadenoma papilliferum and trichoblastoma. And this is a very nice trichoblastoma there with associated follicular stroma on the outside. And that's the sort of the precursor up the top there. So you've got lots and lots of trichoblastic foci, and there's another one over there. And then after that, you can get sebaceous tumors, you can get sebaceous carcinoma, you can get K-like squamous proliferations, you can get true squamous carcinoma, you can get basal cell carcinoma, a real basal cell carcinoma, not this thing, and most importantly, you can get malignant sweat gland tumors, and they are high-grade tumors. So if you get one of those in a Nevus sebaceus, it's bad news. And here, this is pigmented trichoblastoma, and you can see the basophilia of the cell population with peripheral palisading. So it does look a bit like a BCC, but there isn't any cleft formation outside the tumor cell population, and it's got a very much a follicular stroma. And there you can see lots of pigment dotted throughout the tumor. And then here's I put this one in because it's one of my own cases. This is one of the earliest cases I ever saw, and it's very pretty. You can see the high-level sebaceous glands, and you can picture that opening up onto the surface of the skin, and there's a hair, but there's no hairs here. And this is another syringocystadenoma papilliferum, and here you see lots of plasma cells. Now, I don't know why you get plasma cells in this tumor. It's one of those things that I've often thought, gosh, I must try and find out why you get them, but I've never actually investigated it further. Now, there's something funny is going on, so I just want to get, lastly, I want to touch on differential diagnosis, which I'll come back to in the next talk, because there's a lot on it. And I just want to remind you about desmoplastic trichoepithelioma, which you see on the right-hand side, top and bottom. And the similarities are the keratocysts, shown in close-up view here, and the narrow epithelial strands with really no cytological atypia. So those two bits are common to both tumors. But desmoplastic trichoepithelioma is restricted to the, I don't know, the mid-reticular dermis. It's mostly occurring in the papillary dermis and the continuation of papillary dermis around the hair follicles. So most of this tumor that looks as if it's deep is actually follicular stroma with this tumor in it. So you don't see it really down in proper reticular dermis, which is sort of what you're looking at there. And the other thing, as I mentioned to you, is you don't see ductal differentiation ever. If you get a shave biopsy of one of these things, then be very careful. Do a diastase PAS. By all means, do EMA and CEA. But negativity doesn't mean that you couldn't be looking at a MAC. That's the problem. So with a shave biopsy of one of these, I end up telling them, well, you're going to have to do a proper re-excision, because I can't tell you which of these the two tumors is. And that's probably the biggest problem that you'll encounter nowadays is shave biopsies of this tumor. And I think I'm going to stop now, because otherwise I'm going to end up moving into a whole different... I'm going to be talking about all of these entities in what I think will have to be the next lecture. So if it's okay with you, I'm going to stop sharing my screen now, and let's see where we are now. So is that okay?
That's perfect, Prof. Thank you very much. I think before we open it up for questions, etc., I think this is, if one ever sees something called the master class, this is the definition of what the master class was. Thank you very much. I mean, you are a rock star, the amount of experience and everything. But to me, what is fascinating, and I must compliment you, is the quality of your photomicrographs, especially the low power ones. I will one day find out from you exactly how to do it and so on. That's so great to see. Congratulations and thank you very much on that one.
I can respond to you in a way, because I used to take great pride in my photography, and I go to a meeting and I look at everybody else's and say to myself, well, that's terrible. You really need to buck up and do better photography. And then you see the whole world change with slide scanning, and nowadays you don't need any photographic skills whatsoever. So I've become totally redundant. I used to use Agfa 50 ASA film, and I swore by that, and I said the only decent photographs are with proper microscopy. And then when I was living in Arizona, the gentleman from oh gosh, well, I've forgotten what microscope I had, but anyway, whatever it was, he came out to service it for me, and he said, I see you're still using film to take your photographs. And I said, yes, of course I am. You can't take decent photographs without a film camera. And he said to me, I'll tell you what, I'll just pop out to the car and I'll put a camera on your microscope just to see, so you can see what it's like. So I said okay, and I looked at the monitor and I thought, oh God, what have I been wasting my time doing? This is just so good. And so I was instantly converted, and I had to, it was like heresy, treason. I had to take my word back and say, really, yes, this is great. And then in the last few years, people scan their slides, and I quite often get cases now in consultation, and I sit and I think, this is so cool. Who needs a microscope? You don't need a microscope anymore. And in fact, I have a friend, I won't say where he's from, but his laboratory, there are 7 or 8 of them, and they don't use a microscope at all anymore. They sit round a very large monitor on the wall, and they work their way through all their scanned cases and report them from the monitor. And I think that's just the ultimate. It makes it such a pleasant experience. You can sit back and drink coffee and smoke your pipe and just take it easy. But that's anyway. So that's photography for you.
Anyway, your images are very impressive. That being said, I'm sure we'll ask a couple of questions for Professor McKee. One can either please just unmute yourself and go ahead and pop a question, or you can start doing so by chat, and we can read the questions from there. Anybody? Wayne, are we start kicking off with you?
Yes, thank you. Thanks for that. That was a fantastic talk. Your images are just gorgeous.
I can't see you, Wayne. Your camera's not on.
My video's not. My camera won't switch on for some reason.
Oh.
But yeah.
We did. There you are. There you are. You're as handsome as ever.
Some may disagree. A question, if I may.
Sure.
What's your opinion of the relationship between squamoid and ductal carcinoma? Do you think they are one and the same thing, or
No.
a morphological continuum?
No, I think squamoid eccrine ductal carcinoma is something that in the old days we used to call adenosquamous carcinoma. And to me, squamoid eccrine ductal carcinoma, the top half looks like squamous carcinoma, the bottom half looks like ductal carcinoma. And I'm going to show some examples of that in my next talk. And I think it's an unfortunate term because it confuses everybody. And this is one of the big problems in pathology, not just dermatopathology, but pathology as a whole, is people like to write a paper, and if they've got nothing else to say, they change the name and they publish it. And so we've ended up with squamous eccrine ductal carcinoma, and people think of it as, get muddled, as this a variant of MAC, but it's not. It's quite different. And as I say, in the old days, we used to call this adenosquamous carcinoma. It's a mixture of squame at the top and adeno underneath. So that's how I view it anyway.
Thank you. I have a comment, if I may.
Sure.
Yeah, go for it, please.
I think one of the things that can really trip one up is the clinical pathological, or if one trips up with clinical pathological correlation. When they occur in the periocular area and a punch biopsy is sent, they can look so incredibly like seringoma, and we all know serinomas are a preferential periocular areas, a preferential site. And if you don't correlate clinically, it's very easy to misdiagnose punch biopsies as seringoma, and I've nearly been caught out by that. The telephone usually helps one out.
Yes. I think that's an important point. The other thing clinically is syringoma is much more commonly multiple, and so you get a whole lot of them. So clinically, the dermatologist or the clinician should know that they're looking at a syringoma in the first place. So it in a way, if there's confusion, it's because they haven't said in the clinical request, clinically looks like syringoma, and then you're in the right direction. But if you get an absence of any clinical information, I think with a punch, that's a jolly important point. Although from a practical point of view, I've not had that as a problem. But then I think I've lived in a very privileged ivory tower, and I have a deluge of stuff that means that I don't see that so often. But I think it is an important point.
Thank you.
Thank you, Wayne. Anybody else? Don't see if you can chat.
Whoops, I'm just going to close this.
Okay. Anybody else for the last chance while we have Professor McKee for the first part?
Yeah. Well, I think I probably talked so much. There's nothing left to say about it. Really, you can only say so much about it.
I can tell you one problem.
I've probably managed to sort of say everything that's conceivable. So what do you think? Should we perhaps draw this to a close, and then I'll stop recording it, and then we can discuss when we want to meet up again. Would that work?
That will work. Thank you. You can stop recording.
All right. Let me just. I've got to find that. Okay. So.